In this video, we'll discuss 7 of the most important questions about the renal system. Our first question is, a nurse is assessing a patient who has an arteriovenous fistula for hemodialysis, which finding indicates that the fistula is functioning properly. This means that we have created an arteriovenous fistula in the patient for dialysis. Which finding indicates that the fistula is functioning properly? This means we need to see which of these findings indicates that the AV fistula we created is working properly. So an AV fistula means a connection is made between an artery and a vein, and anastomosis is performed, which we will use during hemodialysis. So to check the patency of that fistula, we need to see which of these options indicates that our fistula is working properly. So option A, cool skin over the site. If our fistula is made here and the skin further down is cool, it means the blood supply to that area has decreased. As we might have seen, when an AV fistula is created in a hemodialysis patient, there's a chance of Steele syndrome. Steele means to take away, which is why it's called Steele syndrome. And what happens in that Steele syndrome, the skin further down, if we made the fistula here, then the distal skin beyond it will become cool, and there might be cyanosis. And a weak pulse might be felt, meaning the pulse will feel weak. So we call all of these Steele syndrome. So this means it's a complication. If this happens, we must inform the doctor so they can surgically do whatever's necessary for this fistula. This means that the fistula is not working well here. So this option will also be incorrect here. The second option is absence of vibration. Absence of vibration here means that whenever blood passes through the fistula we created, when we touch it and check, we feel a vibration. We call that feeling, that vibrating feeling, a thrill, meaning when we touch over the fistula, we feel a thrill inside, meaning we feel its vibration, which is normal and should be there. If there's no thrill, it means there's no vibration, which means that the fistula we created is not allowing blood to flow properly. So there might be an occlusion in the fistula, or there might be a clot, some clotting. So absence of vibration means if vibration is absent, it means the fistula isn't working properly. So this option will also be incorrect, because we need to choose an option here that indicates patency, showing that the fistula created is fully patent and ready for use. The next option is presence of the thrill and bruit, meaning in the AV fistula we created, we have a thrill and a bruit. Both of these are present. A thrill is when we palpate and feel a vibration, and a bruit is when we listen with a stethoscope. When we place the stethoscope over the AV fistula and listen to it, we hear a whooshing sound is heard. That whooshing sound is called a bruit. That also occurs when blood flows properly through the AV fistula. This means the presence of a thrill and the presence of a bruit. Both of these are found at the fistula. This means our fistula is working properly. This option indicates that the fistula is patent, and that is exactly what the question is asking. And then we will see what happens. The next option is that the AV fistula is functioning properly. So the correct option here is the presence of a thrill and bruit. The next option is severe pain at the access site. If there is significant pain at the AV fistula site, it means there is some complication. When an AV fistula is first created, the patient may experience mild pain at that time. As the fistula site heals, the pain usually disappears. If there is pain, it means the fistula is not working properly. We must inform the doctor. If there is pain, it means our fistula is not functioning properly. So this option will also be incorrect. The correct answer will be the presence of a thrill and bruit. Before we look at this, we need to look at the types of fistulas. This is our arm. On one side, we have an artery, and this is the radial artery, as you can see, and on the other side, we have a vein located on the opposite side. This is called the cephalic vein, which is known as one of the major veins in the human body. If we create a fistula between these two by performing an anastomosis or connection, it is called an AV fistula or arteriovenous fistula. A fistula that is created near the wrist, which is the area on the lower part of your arm just above your hand, is known as a radiocephalic fistula, This name comes from the fact that it connects the radial artery to the cephalic vein in that region. Fistula. It is created near the wrist. We sometimes make it here, but our first choice is near the wrist. But sometimes the doctor creates it near the elbow, so the vein is located right here, and the artery is here as well. This particular artery, along with the vein on one side, are both present in this area. Anastomosis is performed between these two. The fistula is formed. The artery inside this will be the brachial artery, so this becomes brachial, and the vein will be the cephalic vein, so this becomes a brachiocephalic fistula. Sometimes, instead of here, we create the fistula a bit higher up, that is, above the elbow, so in that case, this is the brachial artery, and the vein we have here, as you can see, is the basilic vein, and an anastomosis is performed between these two. So a fistula is created right here. Now, this artery was brachial, the vein is basilic, so this will become a brachiobasilic fistula. Now, whenever this fistula is created in that arm, meaning the arm with the fistula, we must never measure blood pressure in that arm, because whenever we measure blood pressure and wrap the cuff here, it will compress it. Compression means it will damage the fistula. So we should never measure blood pressure from that arm, nor should we ever insert a cannula into that hand. No cannula should be used. We won't give any injections or apply any tight compression bandages to it, because all of these actions can damage it. So you must keep these things in mind. They could be asked in the NCLEX exam. Like, what actions should a nurse avoid if a patient has an AV fistula? So never check blood pressure in the arm with the AV fistula. Never insert a cannula into it. Never give an injection in it, and never apply a tight bandage to it. One thing we observed was that the arterial... What exactly is Steele syndrome after an AV fistula? This is Steele syndrome. A syndrome means a group of many symptoms. And Steele, as the name suggests, means to take away. So this means when the blood supply was coming from here, instead of going forward like this, it bypassed through this fistula and came to this side instead. So on the forward side, distal to the fistula, the blood supply decreases. This means this fistula stole or reduced the blood supply further down. This is what we call Steele syndrome. Consequently, less blood reaches the forward area, and when less blood reaches it, the distal part beyond the fistula will become cool to the touch. There might be numbness, it could lead to ischemia, and it might even show signs of cyanosis. And if this happens, we must inform the doctor immediately so they can perform the surgical reconstruction. So that was our first question. After this, we'll move on to the second question. Which assessment finding is the most accurate indicator of fluid retention in a patient with renal failure? We need to keep two things in mind here. Our patient has renal failure and they are experiencing fluid retention, but the question asks for the most accurate indicator. This means when fluid retention occurs in a renal failure patient, what's the most common indicator that tells us the patient is retaining fluid? First is blood pressure. Blood pressure might change if there's fluid retention, but this isn't the most reliable indicator. So this option is incorrect. Second is pulse rate. Pulse rate changes, but it's not the most reliable. A pulse rate change could be due to other reasons. For example, if a patient has hypovolemia, tachycardia will occur. Or if the patient is stressed, tachycardia occurs, or if they're in pain, tachycardia also occurs. This means that change in pulse rate could be due to a different reason entirely. So this isn't the most reliable indicator either. The question asks for the most accurate, meaning most reliable. So we can't trust this either, as it could be due to other factors. This means this is also wrong. Next is the daily weight option, which is the most important, reliable indicator when there's fluid retention. Because in kidney patients, The kidney's main job is to remove metabolic waste products like urea and creatinine. Besides that, it maintains fluid balance. When urine is excreted, it means fluid is being filtered and removed from the body. But when kidney failure occurs, this function becomes impaired. This means the kidney can't remove the fluid, so it gets retained inside the body. But how will we know? The most reliable indicator is daily weight. We make it a point to weigh the patient every single day, making sure to do this at the same time each morning to keep our measurements as accurate and consistent as possible. In clinical practice, it is generally believed that if a patient's weight increases by about 1 kilogram within a 24-hour period, we can reasonably assume that the patient is retaining approximately 1 liter of water in their body. This is because 1 liter of water weighs roughly 1 kilogram, so a sudden increase in weight is often due to fluid retention rather than other causes. Among all the available ways to check for fluid retention in patients, monitoring daily weight changes is considered the most reliable and trustworthy indicator, as it provides clear and objective evidence that can help guide patient care. It happens, so that's why the patient's weight must be monitored daily. We should use the same scale for weighing bin at the same time, and along with that, the patient's daily weight. This means the correct answer here will be daily weight. Some students might choose pulse rate, but pulse rate isn't the most reliable. Let's look at the last option, respiratory rate. The respiratory rate can also change when there is fluid retention, because when fluid is retained in the body, pulmonary congestion occurs, because fluid will also start to be retained in the lungs, which we call pulmonary congestion. And if there's pulmonary congestion, the exchange of oxygen and gases won't happen properly. And if gas exchange doesn't happen, the patient might develop tachypnea, but this isn't its most reliable indicator. The most reliable indicator is the weight one. So that means we'll mark this as a wrong answer as well. So the correct answer here will be daily weight. So whenever there's fluid retention in a patient, we must weigh the patient daily. Let's move on to the next question. Which finding is considered the hallmark characteristic of nephrotic syndrome? Hallmark? Hallmark means the most prominent characteristic of it. Which finding is considered the hallmark characteristic of nephrotic syndrome? So what is the main characteristic or the main sign and symptom of nephrotic syndrome? That's what's being asked here. Now, all of them might seem correct, but we have to identify the most important one. Which one among these is the most primary? So the first one is hematuria. Hematuria isn't seen in nephrotic syndrome because hematuria is mostly seen in nephritic syndrome, not nephrotic. There's a difference between nephritic syndrome and nephrotic syndrome. So RBCs pass through into the filtrate, meaning RBCs don't usually come out of the nephron. But if there's inflammation in the glomerulus, then the capillaries there become leaky. This means RBCs leak out through the urine, which we call hematuria. But that happens in nephritic syndrome, not in nephrotic syndrome. So one is nephritic syndrome. When nephritic syndrome occurs, RBCs will be excreted. If RBCs are excreted, then hematuria will occur. But this won't happen in nephrotic syndrome. Nephrotic syndrome is something else. Nephrotic syndrome. In nephrotic syndrome, protein is excreted because the filtration barrier in the kidney is damaged, and if that happens, it can result in proteins, which are normally kept in the bloodstream, leaking into the urine. This loss of protein can then lead to a variety of symptoms and complications that are associated with nephrotic syndrome. If the filtration barrier is damaged, protein will be released. Because the filtration barrier that stops protein is damaged, protein will come out. So here we have hematuria, which is incorrect because it's not a characteristic of nephrotic syndrome. Proteinuria greater than 3.5 grams per day. If 3.5 grams of protein is excreted in the urine daily, that's proteinuria, and it's the hallmark sign and symptom. So that means option B is the correct answer here. Then we have hypokalemia, option C. In most cases of nephrotic syndrome, there is no such effect. So we can rule this one out as well. And polyuria. Polyuria means if more than 3 liters of urine is excreted in 24 hours, we call it polyuria. But in nephrotic syndrome, it's mostly protein that's lost. After protein loss, edema occurs in the body and cholesterol and lipids increase, which we call hyperlipidemia. So these are the symptoms that occur. If we want to look at the difference between nephrotic and nephritic syndromes, it's important to understand what sets them apart and why that matters for diagnosing and treating kidney conditions. We'll take a closer look at how these two syndromes differ, what makes each one unique, and why recognizing these differences is crucial for providing the right care. By understanding the key features of nephrotic and nephritic syndromes, you'll be better prepared to identify them and make informed decisions in a clinical setting. Nephritic syndrome, now we'll see it here in this section, and we'll talk about what it means. This is the nephron, and within the nephron, there's a section with a network of capillaries. This is called a glomerulus, and the part below it is called Bowman's capsule. Usually, in nephrotic syndrome, the filtration barrier is damaged. This barrier is composed of three things. First, this cell, which is called an endothelial cell. Secondly, this structure is known as the basement membrane, which forms a thin, specialized layer. On top of this basement membrane, there is a particular substance called heparan sulfate. Remember, it's heparan sulfate, not heparan sulfate. These names are easy to mix up because they sound so similar, but it's important to use the correct one. Heparan sulfate is the right term here, and getting it right helps avoid confusion. So just to be clear, this is heparan sulfate, not heparan sulfate. It has a negative charge. Proteins are also negatively charged. And since both have a negative charge, they repel each other. If there's protein here and heparan sulfate here, as soon as the protein gets close, it's pushed away. This means that the heparin substance is present here. And if this heparan sulfate is in the basement membrane, as soon as protein arrives, it's repelled back. So the protein goes this way, not through it. But what exactly happens in nephrotic syndrome? In nephrotic syndrome, the filtration barrier will break down. As it breaks down, it means there's no substance or barrier left to repel the protein. The protein will leak out from here, and from here, it will leave the body through the urine. This is what we call nephrotic syndrome. But if I talk about nephritic syndrome, then in nephritic syndrome, all three layers of the filtration barrier remain intact. But there's inflammation in the glomerular capillaries, and if they're inflamed, their pores will enlarge, and because of those large pores, red blood cells will leak out, but protein will not. Because to repel protein again, we still have the basement membrane. In that basement membrane, there's a negative charge called heparan sulfate, which repels the protein. Protein will move forward, while red blood cells will pass through it. So red blood cells appear in the urine in nephritic syndrome, and protein appears in nephrotic syndrome. Let's move on to the next question. Which instructions should the nurse include when teaching a female client how to prevent a urinary tract infection? Which instruction should the nurse include when teaching a female client how to prevent a urinary tract infection? So we need to choose the correct statement. So the first one is delay urination when busy. This means we'd be telling the patient that they should delay. You really shouldn't do this because the longer you delay and keep holding your urine in your bladder, the higher your risk of developing a urinary tract infection or UTI becomes. It's important to remember that holding it in for too long can make things worse over time. When urine leaves the bladder, it flushes it out, and any bacteria entering, like E. coli, gets flushed out when we urinate, so the chances of a UTI will be lower. But if you hold it for a long time, the chances of a UTI will be the duration of the flush will be reduced and the frequency of the flush will be reduced. So because of this, E. coli will travel back up and enter the bladder. If it enters the bladder, it means the chances of a UTI will increase. So we never tell the patient that they should hold their urine or delay urination. So this first option doesn't prevent a UTI. So this will be our wrong answer. Limit fluid intake. If we reduce our fluid intake, we'll produce less urine, which means we'll be urinating less frequently. And if we urinate less often, there's less flushing, which means we can't flush the bacteria out of the system. So that means we actually need to drink more water. Whenever you have a patient with a UTI, tell them to drink at least 2 to 3 liters of water every 24 hours. The reason for this is that the more water you drink, the more urine your kidneys will produce. This helps to flush out any bacteria that have entered the bladder. This means we're flushing out bacteria from the urinary tract, so we shouldn't limit fluids. We should encourage drinking more water. So this option is also incorrect. The next option is to wipe from front to back after using the toilet. After toileting, we advise the patient to wipe from front to back, meaning from the urethra toward the anus. What happens is that E. coli bacteria are naturally present in the GI tract, specifically in the colon and the anus. They can come out and migrate into the perineal area. And if we wipe after using the toilet from back to front, then by doing so, the perineum area from the urethra, after reaching the urethra, they will go inside into the urinary bladder and cause a UTI there. So we will definitely not do that. We have to tell the patient that you need to clean from front to back, okay? So you have to wipe from front to back. So what will happen is that the E. coli bacteria in the perineum area, or the anal area, won't reach the urethra. So what's done here? Wipe from front to back. Okay, so that means this is correct. This protects us from UTIs, so we'll mark this as the correct answer. The last option is use bubble baths daily. Taking daily bubble baths doesn't reduce the chances of a UTI, it increases them. Because when we take a bubble bath in that water, meaning what we call very scented soaps are mixed in. And because those scented soaps are mixed in, due to that, they will irritate the lower part of the urethra. And besides that, in our urinary tract or urethra, some of the normal flora, well, they will destroy them. So that's why we shouldn't tell the patient to take daily bubble baths either. So this won't protect us from it either, so this will also be a wrong answer here. Now let's talk about the next question. Which symptom is most characteristic of renal calculi, meaning kidney stones? So if there's a stone in the kidney, then which symptom tells us that it's pain from a kidney stone? Whereas for the most characteristic of renal calculi, meaning the patient has a renal stone. So which symptom indicates it's a kidney-related symptom? We have to choose that in this. The first option is chest pain. Chest pain has nothing to do with it when there's a stone in the kidney, because chest pain is mostly related to the heart. So that means this will also be wrong here. Option B, severe flank pain that radiates to the groin. Yeah, flank pain can occur because our kidney's location is in the flank region. So that's why we can say that if the kidney is in the flank region, there will be pain there that radiates to the groin. It's radiating to the groin because, let's say, if there's a stone in the kidney and it's passing forward and has entered the ureter. So the lower part of the ureter, we divide the ureter into 3 parts: upper ureter, middle ureter, and lower ureter. The lower ureter and the nerves within it, or the pain nerves coming from there, go to the same segment of the spinal cord where the nerves from the groin skin also enter the same area. So the brain then interprets that this pain might be in the groin area. So this option is correct because the pain will be in the flank and it will radiate to the groin. We'll see this further, how it radiates, so this will be the correct answer. Headache? As for headache, we can't really say that the headache is caused by this. We can't say the headache is due to a kidney stone, so that's a wrong answer too. Bradycardia isn't caused by kidney stones either. There can be many other causes for bradycardia. So if the pain is in the flank area and it radiates to the groin, we can say it's kidney stone pain. To understand the story behind why this pain radiates, we have to look at this. Look, this is the anterior view. So there will be pain in the flank area here, and it will radiate to the groin area. In males, it might go to the scrotum. In females, it might go to the labia. We can say it goes to the genitalia. And this right here is the posterior view, which clearly shows that pain typically occurs in the flank area, which is located on the side of the body just below the ribs. But why exactly does this pain tend to radiate when someone has renal stones? To really understand why the pain radiates in this way, we have to take a closer look at something important, our brain. And just below the brain, all of this is the spinal cord. And different spinal nerves actually emerge from different segments in it. Now, at this point, we have to see and understand that when this is our kidney, they actually carry the pain from here, from this specific region. We must have seen, or at least noticed, that within our spinal cord, there are a total of 31 pairs of spinal nerves. So they emerge from these different spinal sections, each one coming out from a particular segment. Now, we have to see and try to understand why kidney pain, or the pain that originates from the kidney, radiates to the groin and where it will be. So to see where it radiates, we have to see that the sensory nerve fibers emerging from the kidney will go from here to the T10 segment, T11, and T12. When there's pain in the kidney, meaning a stone in this renal pelvis area, then these nerves will carry the sensation of pain into the T10, T11, and T12 spinal segments. But if in this same area, now here, nerves are also coming from the flank area on the other side. They are carrying pain, plus nerves from the upper abdomen are also carrying pain. So this kidney pain, if there's a stone in the kidney, will go to the flank area and can also radiate to the upper abdomen. But if we talk about the ureter, the nerves that emerge from the ureter, we've shown the ureter in 3 parts here: upper ureter, middle, and lower. For the upper, the nerves from here will go to the same segment where the ones from the kidney were going. So these will go to T10, T11, and T12. This means if the stone is in the upper ureter, the pain will still radiate to the flank and upper abdomen, because here, in the same segment, the nerves coming from the other side are carrying pain from the dermatome. A dermatome is an area of skin. In our body, different nerves supply a specific area of the skin, and that's what we call a dermatome. For example, if a nerve is coming to this particular area, then it's a dermatome, a specific area of skin supplied by a single nerve, so we call it a dermatome. So if there's a stone in the kidney, let's say it's in the renal pelvis, or in the calyx, then the pain will radiate to the flank area and upper abdomen. If this same stone moves into the ureter, then the pain will radiate to the same place as it did for the kidney, because the nerves are going to the T10, T11, T12 area. If this same stone moves further down into the middle area, then the middle area of the ureter, the nerves from here will go to the T11 and T12 segments. But in the T12 and T11 segments, we also have nerves coming from some dermatomes from the lower abdomen. So this means if the stone is in the middle ureter, then the pain will radiate to the flank area and the lower abdomen. If this same stone descends even further and reaches the very bottom part of the ureter, in the lower ureter, then where will the pain radiate? Then the site of pain radiation will be different. Now, the nerves coming out from here travel specifically into the L1 and L2 segments. In the L2, L1, and L2 segments, and in this same segment, we have nerves from the other side that bring somatic pain, and those are from the groin area. The groin, which is also known as the genital area, refers to a region that includes the scrotum in males and the labia in females. So when we talk about pain that radiates to these areas, we mean discomfort that spreads from one part of the lower body to another, such as from the lower abdomen into the scrotum for men or into the labia for women. If there's a stone in the lower ureter, then that pain will radiate into the groin and genitalia, and it could also be in the inner thigh. And the reason for this is that in that segment where these pain nerves are going, nerves from the groin, genitalia, and inner thigh are also coming into that same segment. So the brain first thinks that this pain coming in, if this pain is visceral pain because it's coming from an organ, and the nerves from the other side, what's coming is somatic pain because it's coming from the dermatome. Dermatome means the skin area. So when our brain interprets this pain, it first senses the somatic one much more effectively. So the brain thinks this pain might be coming from the groin or genitalia, so we can call this referred pain. Because the pain is occurring here, but it's felt in the groin and genitalia, so we call it referred pain. If this same stone has moved forward into the bladder, if the stone has entered the bladder, then where will the bladder pain be referred? Bladder pain does occur in the suprapubic area, because that's the origin, but the pain will also be referred. If that pain is referred, then the pain nerves from here go to the S2, S3, and S4 segments. In this same segment, we also have nerves coming from some somatic areas. And those nerves will actually travel into the perineum region, for example, like the pudendal nerve, which is important for sensation and function in that area. So these nerves will come from the perineal region specifically and play a key role in the function of this part of the body. So here, if there's a stone in the bladder, then we'll feel this pain in the suprapubic area, but that pain will also radiate and it will go to the perineum because the nerves exiting the bladder go to the S2, S3, S4 spinal segments. And nerves from the perineal area also come into the same segment. And this perineal area is a dermatome, a part of the skin. So if the brain thinks from both sides that there's pain in the dermatome or pain in the skin, it interprets that this pain is occurring in the perineum. So this means if there's a stone in the bladder, it will be referred to the perineal area. If there's a stone in the lower ureter, it will be referred to the groin or genitalia. And if there's a stone in the middle ureter, its pain will radiate to the lower abdomen or the flank area. If there's a stone in the upper ureter, its pain will be referred to the upper abdomen or the flank area. And if there's a stone in the kidney, meaning a stone in the kidney is either in the calyx or the pelvis, then its pain will radiate within the flank area or the abdomen itself. Now, let's move on to our next question. Which symptom is commonly observed during the early stage of chronic kidney disease? Which symptom is commonly observed during the early stage of chronic kidney disease? CKD. This means it's asking here which symptom is commonly observed during the early stage, meaning the initial stage of kidney failure, specifically the early stage of chronic kidney failure. Which symptom will we see in that? So anuria. Option A, anuria. Anuria means if the urine output is less than 100 ml in 24 hours, it's called anuria. But this doesn't happen in the early stage of chronic kidney disease, or CKD, so we'll mark this as wrong too. Nocturia. Nocturia means an increase in urination during the night, meaning an increase in the frequency of passing urine at night, is called nocturia. And nocturia starts occurring in the early stages of CKD, which is chronic kidney disease. Nocturia begins then, because our kidneys contain nephrons, and the collecting duct part of the nephrons concentrates the urine. This means it reabsorbs water from the filtrate before urine is formed and puts it back into the capillaries, which means urine production will then decrease. But what happens in chronic kidney disease or chronic kidney failure? The kidney has stopped doing this work. The cells in the renal tubules of the kidney have stopped functioning. This means the urine won't be concentrated. If it's not concentrated, it means the urine will be very dilute. Being dilute means the person will pass urine frequently, and they'll pass urine frequently, especially at night, which is why we call it nocturia. And why does this happen at night? Because during the day, the patient walks or stands, so the fluid in our body, while you might have seen that a chronic kidney disease patient has edema. Edema means fluid has shifted into the tissues throughout the body. So when the patient stands, the fluid stays shifted into their legs towards the bottom, so venous return is reduced. Reduced venous return means less fluid reaches the kidneys, so less urine is produced during the day. That's what happens during the day. But at night, when we sleep and lie flat on the bed, the fluid from the legs also increases again through venous return. Venous return increases, and more of that fluid reaches the kidneys. When more fluid reaches the kidneys, the nephrons produce more filtrate. And then, as a result, more urine is expelled from the body. This is the reason why nocturia, which means waking up at night to urinate, is what we commonly observe. High urine output isn't seen during the day because the patient is standing, so the fluid is shifted into the legs. So at night, as soon as they lie down, the fluid that was shifted in the legs due to edema also enters venous circulation. increasing venous return and sending more fluid to the kidneys. So more urine will be produced, leading to nocturia. Therefore, this option is correct here. Next is severe edema. Severe edema will occur, but the question asks about the early stage. Severe edema won't happen in the early stage, it occurs in the late stage, so this is also incorrect. Hematemesis. Hemat means blood, and emesis means vomiting. So hemat means blood, and emesis means vomiting. That is, if blood is appearing in the vomit. If there's blood in the vomit, this symptom isn't even related to the kidneys, so we'd mark this as wrong anyway. Now, let's take a look at why this nocturia happens. Basically, what occurs is that when we are lying down, fluid is in the legs, shifted, and during the day, if the patient is walking, standing, or sitting, the fluid is shifted to their legs, so not as much urine is produced as at night. When fluid is processed at night, more fluid reaches here, more blood reaches here, so more filtrate is formed, and more filtrate means more urine is produced. But what happens in chronic kidney disease is that our collecting duct, now as urine is formed here and comes down like this, it will just pass right out. This means that normally in us or in a healthy patient, there are certain cells on this collecting duct, like these white ones I've shown here. We call these cells principal cells, and these principal cells function under the influence of ADH. The more antidiuretic hormone that is produced in our hypothalamus, it then gets stored in the posterior part of the pituitary gland and is released from there. When ADH enters the kidney, it acts right here. When this ADH, or antidiuretic hormone, reaches these principal cells, they reabsorb the water from the incoming filtrate and put it back into the capillaries. That's the job of ADH. This happens in a normal person, but in a patient with CKD, the cells found within these tubules, they stop working effectively. Because of kidney failure in its initial stages, they stop functioning. So even if ADH comes from above, they won't be able to reabsorb the water from here. If they can't reabsorb it, more urine will be produced, and more will be produced at night. That's why we call it nocturia. And mostly, you see, the concentration is low in this, meaning in the early stages, the kidney can't concentrate urine. Normally, as urine flows out here, it's put back into the capillaries. If it's put back into the capillaries, the urine that eventually leaves the body will be concentrated or thick. But when these principal cells in the kidney tubules are damaged, they can't reabsorb water from the filtrate that becomes urine. If they can't, more urine is produced, which means it's diluted urine, so the patient has to go frequently, and since it's more at night, we call it nocturia. All right, now let's discuss the last question for today. A nurse is caring for a client diagnosed with acute kidney injury. This means the patient has a kidney injury, specifically an acute one, AKI. So a nurse is caring for a client diagnosed with acute kidney injury, AKI. The nurse reviews the following laboratory results. So in that, the potassium is 6.4 milliequivalents. This means it's a bit elevated because the normal range we have is 3.5 to 5.5 milliequivalents per liter. So this means the potassium is high here, which is hyperkalemia. The second lab value is creatinine. Creatinine is 2.1 milligrams per deciliter. The normal level for creatinine is 0.6 to 1.2 milligrams per deciliter. This means the creatinine is also high here, which shows that the kidney has slowed down or stopped working altogether. That's why the creatinine in the blood is increased. Usually what happens is that creatinine is produced from our muscle metabolism, but it's excreted by the kidneys. But when the kidneys aren't working properly, they can't filter out this metabolic waste. If they can't, it accumulates in the blood, and the creatinine level in the blood will rise. The third lab value is BUN, 38. BUN means blood urea nitrogen, 38 milligrams per deciliter. Its normal range is 7 to 20 milligrams per deciliter. So this means that BUN is also elevated. And this elevated BUN indicates that the kidney has stopped working because BUN is also a metabolic waste that the kidney hasn't been able to excrete. The last lab report is sodium, 134 milliequivalents per liter. Now, the normal range for sodium is 135 to 145 milliequivalents per liter. This means there's hyponatremia here. Now, the question asks, which lab finding requires immediate nursing intervention? This means all these lab values might be altered or changed, but we need to identify the one that requires immediate nursing intervention. Otherwise, it could be dangerous for the patient. So the first option, A, creatinine, 2.1 milligrams per deciliter. The creatinine is high, meaning metabolic waste isn't being excreted, but this isn't immediately life-threatening for the patient, so we don't need immediate nursing intervention for this. Option B is potassium, 6.4 milliequivalents per liter. The potassium is high. We must remember that whenever potassium rises, it's called hyperkalemia. And if hyperkalemia occurs, there will be a change in the patient's heart rhythm, which we call cardiac dysrhythmia. So if the potassium level is high, the patient will have cardiac dysrhythmia, which can eventually lead to cardiac arrest. Therefore, we need to address this lab value first. And for this, we need to intervene so that we can start cardiac monitoring for the patient, like attaching ECG electrodes. And after that, we'll start noting the ECG, start watching the ECG. If the patient has a tall T wave, then we can say that the patient is showing more symptoms of hyperkalemia. So we'll have to inform the doctor about that. So this option is correct, option B. Potassium is 6.4 milliequivalents, so we need immediate nursing intervention. Option C, BUN38, this means blood urea nitrogen is indeed elevated, but we don't need any immediate intervention for this. Sodium, 134 milliequivalents, is an option D, so this is also a bit lower than the normal range, but we don't need immediate intervention. So the correct answer here will be option B, which states that potassium is 6.4 milliequivalents per liter. So these were some of our important questions related to the renal system for today. Tomorrow we will be back again with a new video and some new questions. Thank you.